Hello everyone, starting with chapter 3 of illustrated textbook of Pediatrics, normal child development, hearing and vision. Features of normal child development, hearing and vision are children's acquisition of developmental abilities follow a similar pattern. For developmental screening of young children, there are age limits by which time most children have achieved specific developmental milestones. There is an integrated program of screening, tests, immunization, developmental reviews, and health promotions for all children. The Healthy Child Program. All newborn infants have their hearing screened. Assessment of vision relies on parental observation. Screening of visual acuity and squint occurs at school entry. Children acquire functional skills throughout childhood. The term child development is used to describe the skills acquired by children between birth and about 5 years of age, during which there are rapid gains in mobility, speech and language, communication, and independence. During school age, evidence of developmental progression is predominantly through cognitive development and abstract thinking, although there is also some further maturation of early developmental skills. Normal development the first few years of life is monitored by parents who are provided with guidance about normal development in their child's personal child health record and in the book Birth to 5, given to all parents in the UK. At regular child health surveillance checks, whether a young child is seen by a healthcare professional, a brief opportunistic overview should always be made at those times. The main objective of assessing a young child's development is to confirm normality of progress or the early detection of disordered development in order to help children achieve their maximum potential, provide treatment or therapy promptly, particularly important for impairment of hearing and vision, act as an entry point for the investigation, care, and management of the child with special needs. This chapter covers normal development, delayed or disordered development, and the child with special needs are considered in next chapter. Influence of heredity and environment. A child's development represents the interaction of heredity and the environment on the developing brain. Heredity determines the potential of the child, while the environment influences the extent to which that potential is achieved. For optimal development, the environment has to meet the child's physical and psychological needs. These vary with age and stage of development. Infants are totally dependent on their parents for all physical needs and also require a limited number of cares to meet their psychological needs. Primary school age children can meet some of their physical needs and cope with many social relationships. Adolescent and young adults are able to meet most of their physical needs while experiencing increasing complex emotional needs. In figure 3.1 as shown, development can be impaired if the environment fails to meet the child's physical or psychological needs. Physical needs include food, good vision and hearing, warm clothing, shelter, activity with rest, and good health. Psychological needs are security, role models, opportunity to learn from experience, play, affection and care, and personal identity, self respect, and independence. Next is fields of development. There are 4 fields of developmental skills to consider whenever a young child is seen. Number 1 is gross motor. Number 2 is vision and fine motor. Number 3 is hearing, speech and language. Number 4 is social, emotional and behavioral. Gross motor skills are the most obvious initial area of developmental progress. As fine motor skills require good vision, these are grouped together. Similarly, normal speech and language development depend on reasonable hearing, and so these are considered together. Social, emotional, and behavioral skills are a spectrum of psychological development. The acquisition of developmental abilities for each skill field follows a remarkably constant pattern between children but may vary in rate. It is like a sequential story. Thus, the normal pattern for acquisition of skills is sequentially constant, should always be considered longitudinally, relating each stage to what has gone before and what lies ahead. Varies in rate between children. A deficiency in any one skill area can have an impact on other areas. For instance, a hearing impairment may affect a child's language, social and communication skills, and behavior. As a child grows, additional skills become important, such as attention and concentration, and how an individual child manages to integrate their skills. Neglect or child abuse can affect a child at any age but may have a global detrimental effect in younger children. Developmental milestones, chronological age, physical growth, and developmental skills usually evolve hand in hand, just as there are normal ranges for changes in body size with age, so there are ranges over which new skills are acquired. Important developmental stages are called developmental milestones. When considering developmental milestones, the median age is the age when half of the standard population of children achieve that level. It serves as a guide to when stages of development are likely to be reached but does not tell us if the child's skills are outside the normal range. Limit ages are the age by which the developmental milestones should have been achieved. Limit ages are usually 2 standard deviations from the mean. They are more useful as a guide to whether a child's development is normal than the median ages. Failure to meet limit ages gives guidance for action regarding more detailed assessment, investigation, and intervention. Median and limit ages. The difference between median and limit ages is shown by considering the age range for the developmental milestones of walking unsupported. The percentage of children who take their first steps unsupported is 25% by 11 months, 50% by 12 months, 75% by 13 months, 90% by 15 months, 97.5% by 18 months. The median age is 12 months and is a guide to the common pattern to expect. Although the age range is wide, the limit age is 18 months, 2 standard deviations from the mean. Of those not achieving the limit age, many will be normal late walkers, but a proportion will have an underlying problem such as cerebral palsy, a primary muscle disorder, or global developmental delay. A few may be understimulated from social deprivation. Hence, any child who is not walking by 18 months of age should be assessed and examined. Thus, 18 months can be set as a limit age for children not walking. Setting the limit age earlier may allow early identification of problems, but will also increase the number of children labeled as delayed who are in fact normal. Variation in the pattern of development. There is variation in the pattern of development between children. Taking motor development as an example, normal motor development is the progression from immobility to walking, but not all children do so in the same way. While most achieve mobility by crawling, 83%, some bottom shuffle, and others become mobile with their abdomen on the floor, so-called commando crawling or creeping. As shown in the picture, a very few just stand up and walk. The locomotor pattern, crawling, creeping, shuffling, and just standing up, determines the age of sitting, standing, and walking. The limit age of 18 months for walking applies predominantly to children who have had crawling as their early mobility pattern. Children who bottom shuffle or commando crawl tend to walk later than crawlers, so that within those not walking at 18 months of age, there will be some children who demonstrate a locomotor variant pattern with their developmental progress still being normal. For example, of children who become mobile by bottom shuffling, 50% will walk independently by 18 months and 97.5% by 27 months of age. with even later ages for those who initially commando crawl. Some children who walk late have joint hypermobility. Why motor development is most rapid in the first years of life? Motor development journey follows a cephalocaudal pattern, head to toe, in relation to maturation of central nervous system and myelination. Myelin is required for nerves to function properly. The process of myelination in the brain begins in utero and mostly occurs in the first 2 years of life, allowing rapid movement development. Thereafter, it continues to develop at a slower rate in some structures, such as the frontal lobes. Myelination is only complete during adolescence. As in figure, early locomotor patterns, mostly children crawl on all fours prior to walking, but some bottom shuffle and others commando crawl, creep. Bottom shuffling often runs in families. The late walking that often goes with this locomotor variant needs to be differentiated from an abnormality such as cerebral palsy. Adjusting for prematurity. If a child has been born preterm, this should be allowed for when assessing developmental age by calculating it from the expected date of delivery. Thus, the anticipated developmental skills of a 9-month-old baby chronological age born 3 months early at 28 weeks gestation are more like those of a 6-month-old baby corrected age. Correction is not required after about 2 years of age, when the number of weeks early the child was born no longer represents a significant proportion of the child's life. Is development normal? When evaluating a child's developmental progress and considering whether it is normal or not, concentrate on each field of development: gross motor, vision and fine motor, hearing, speech and language, social, emotional, and behavioral separately. Consider the developmental pattern by thinking longitudinally and separate about each developmental field. Ask about the sequence of skills achieved as well as those skills likely to develop in the near future. Determine the level the child has reached for each skill field. Now relate the progress of each developmental field to the others. Is the child progressing at a similar rate through each skill fields, or does one or more field of development lag behind the others? Then relate the child's developmental achievement to age, chronological or corrected. This will enable you to decide if the child's developmental progress is normal or delayed. Normal developmental implies steady progress in all 4 developmental fields, with acquisition of skills occurring before limit ages are reached. If there is developmental delay, does it affect all 4 developmental fields, global delay, or one of the more developmental fields only? Specific developmental delay. As children grow older and acquire further skills, it becomes easier to make a more accurate assessment of their abilities and developmental status. So this is a summary about assessing child development. When assessing a young child's development, consider the 4 fields of developmental skills: gross motor, vision and fine motor, hearing, speech and language, social, emotional and behavioral. The acquisition of developmental abilities follow a similar pattern between children but may vary in rate and still be normal. Term used are developmental milestones, the age of acquisition of important developmental skills; median age, the age when half the population acquire a skill, serves as a guide to normal pattern of development; limit age, the age when a skill should have been acquired; further assessment is indicated if not achieved. When evaluating a child's development, consider each skill field separately, the sequence of developmental progress, the stage the child has reached for each skill field. If progress is similar in each skill field, only at the end the child's overall developmental profile and how that relates to the child's age. Pattern of child's development. This is showing pictorially for each field of development including key developmental milestones and limit ages. Gross motor development, median ages of newborn and 6 to 8 weeks, 8 to 9 months, 6 to 8 weeks, 6 to 8 months, 8 to 9 months, 10 months, 12 months, 15 months. The next is vision and fine motor. Vision and fine motor, median age is 6 weeks, 4 months, 4 to 6 months, 7 months, 10 months, 16 to 18 months, 14 months to 4 years, 2 to 5 years. Next is hearing, speech, and language, and that is newborn. Startles to loud noises, 3 to 4 months, vocalizes alone or when spoken to, cools and laughs, 7 months, turns to soft sounds out of sight, 7 to 10 months. At 7 months, sounds used indiscriminately. At 10 months, sounds used discriminately to parents. 12 months is 2 to 3 words other than dada or mama. 18 months, 6 to 10 words, shows 2 parts of the body. 20 to 24 months, joins 2 or more words to make simple phrases. 2.5 to 3 years, talks constantly in 3 to 4 sentences. Now, social, emotional, and behavioral development, median ages 6 weeks, smiles responsively. 6 to 8 months, puts food in mouth. 10 to 12 months, waves bye-bye, plays peekaboo. 12 months, drinks from a cup with 2 hands. 18 months, holds spoon and gets food safely to mouth. 18 to 24 months, symbolic play. 2 years, day by day pulls off some clothing. 2.5 to 3 years, parallel play, interactive play involving takes turns. Now this is a table of the primitive reflexes, evident at birth, gradually disappear as postural reflexes essential for independent sitting and walking emerge. These are the primitive reflexes: motor reflex, grasp reflex, rooting reflex, stepping response, and asymmetrical tonic neck reflex and sucking reflex. Motor reflex, sudden extension of the head causes symmetrical extension, then flexion of the arms. Grasp is the reflex, flexion of the fingers when an object is placed in the palm. Rooting reflex, head turns to the stimulus when touched near the mouth. Stepping response, stepping movement when held vertically and dorsum of the feet touch a surface. Asymmetrical tonic neck reflex, lying supine, the infant adopts an outstretched arm to the side to which the head is turned. Sucking reflex, child sucks when nipple or tether placed in their mouth, automatic feeding action. Now the postural reflexes, labyrinthine writing, head moves in opposite direction to which the body is tilted. Postural support, when held upright, legs take weight and baby may push up. Bounce, lateral propping, in sitting the arm extends on the side to which the child falls as a saving mechanism. Parachute, when suspended face down, the baby's arms extend as though to save himself. In order to screen a young child's development, it is only necessary to know a limited number of key developmental milestones and their limit ages. Now, cognitive development. Cognition refers to higher mental function. This evolves with age. In infancy, thought processes are centered around immediate experiences. The thought process at different ages are described in table 2.6. Those of preschool children, which have been called pre-operational, taught by Piaget, who described children's intellectual development, tend to be that they are center of the world. Inanimate objects are alive and have feelings and motives. Events have a magical element. Everything has a purpose. Toys and other objects are used in imaginative play as aids to thought to help make sense of experience and social relationships. In middle school children, the dominant mode of thought is practical and orderly, tied to immediate immediate circumstances and specific experiences. This has been called operational thought. It is also in the early to mid teens that an adult style of abstract thought, formal operational thought, begins to develop with the ability for abstract reasoning, testing hypotheses, and manipulating abstract concepts. Now, the summary of fields of development with limit ages. Gross motor development is acquisition of tone and head control. Primitive reflexes disappear. Sitting. Locomotor patterns: standing, walking, running, hopping, jumping, pedaling. And in gross motor, head control is at limit ages is 4 months, sits unsupported 9 months, stands with support 12 months, walks independently 18 months. Now, vision and fine motor development: visual alertness, fixing and following, grasp reflex, hand regard, voluntary grasping, pincer points, handles objects with both hands, transfers from hand to hand, riding, cutting, dressing. Vision and fine motor: fixes and follows visually 3 months, reaches for objects 6 months, transfers 9 months, and pincer grab 12 months. Hearing, speech and language development: sound recognition, vocalization, babbling, single words, understand, simple request, joining words, phrases, simple and complex conversation. Hearing, speech and language, polysyllabic babble 7 months, consonant babble 10 months, saying 6 words with meanings 18 months, join words 2 years, 3 word sentences 2.5 years. Social, emotional, behavioral development: smiling, socially responsive, separation anxiety, self-help skills, feeding, dressing, toileting, peer group relationships, symbolic play, social communication behavior, and social behavior in smiles at 8 weeks, fear of strangers 10 months, feeds self spoon 18 months, symbolic play is 2 to 2.5 years, and interactive play 3 to 3.5 years. And now the next summary of developmental milestones by median age. And age is newborn. Gross motor will be flex posture. Vision and fine motor follows phase or light by 2 weeks. Hearing, speech and language: stills to voice, startles to loud noise. And social, emotional and behavioral: smiles by 6 week. Age at 7 months, the gross motor present would be sits without support. Vision and fine motor transfers objects from hand to hand. And hearing, speech and language turns to voice, polysyllabic babble. And social, emotional and behavioral would be finger feeds, fears strangers. And at 1 years of age, gross motor will be stands independently. Vision and fine motor, pincer grab 10 months, and points. Hearing, speech and language 2 to 3 words, understands name. And social, emotional and behavioral will be drink from cup and babes. 15 to 18 months, gross motor will be walks independently and steadily. Vision and fine motor, immature grip of pencil, random scribble. Hearing, speech and language 6 to 10 words, points to 2 body parts. Social, emotional and behavioral, feeds self with spoon, beginning to help with dressing. 2.5 years, gross motor will be runs and jumps. Vision and fine motor, draws. Hearing, speech and language 3 word to 4 word sentences, understands 2 joint commands. Social, emotional and behavioral will be parallel play, clean and dry. Now, next is analyzing developmental progress, detailed assessments. So far, emphasis have been mainly on thinking about developmental progress in a longitudinal way. Each skill fields and its progression separately, and then relating the progress in each field to that occurring in the others and to chronological age. This is the fundamental concept of learning how to think about developmental assessment of children. Detailed questioning and observation is required to assess children with developmental problems but is unnecessary whilst screening developmental progress in normal clinical practice when a shortcut approach can be adopted. The shortcut approach, this concentration on the actively changing skills for the child's age, the age at which developmental progress accelerates, differs in each of the developmental fields. The figure 3.8 given demonstrates the age when there is the most rapid emergence of skills in each developmental field. This means there is for gross motor development and explosion of skills during the first year of life, vision and fine skill development, more evident acquisition of skills from 1 year onward, hearing, speech and language, a big expansion of skills from 18 months of age, and social, emotional and behavioral development, expansion in skills, particularly from 2.5 years of age. Understanding the time when acceleration in each skill field becomes more obvious and knowing the child's age helps guide initial developmental questioning. Thus, for a child aged less than 18 months, it is likely to be more useful to begin questions around gross motor abilities, acquisition of vision and hearing skills, followed by questions about hand skills. 18 months to 2.5 years, initial development question is likely to be more usefully directed to acquisition of speech, language, and fine motor hand skills, with only brief questioning about gross motor skills, as it is likely the child would have presented earlier if these were of concern. 2.5 to 4 years, initial questions are best focused around speech and language and social, emotional, and behavior development. Developmental question needs to cover all areas of developmental progression, but this more focused way of taking a developmental history allows a useful shortcut approach. It directs assessment to current abilities instead of concentrating on parents trying to remember the age when their child acquired developmental milestones sometimes in the past. Observation during questioning of equal importance to take the developmental history is the examiner's ability to observe the child's almost immediate throughout any visit. To observe the child throughout any visit, not only will this provide an almost immediate guide to where to begin questioning, but it also offers the opportunity for a rapid overview of the child's ability, behavior, peer group, parent-child relationship, all of which will go towards determining the overall picture about the child and his or her developmental abilities. Equipment for developmental testing. Simple basic equipment is all that is needed for most developmental assessment. Equipment is aimed at bringing out the child's skill using play. Cubes, a ball picture book, doll, and miniature toys such as tea set, crayons, and paper allow a quick but useful screen of mobility, hand skills, play, speech, and language and behavior. These items allow the child to relax by having fun at the same time as facilitating observer assessment of his skills. Now, the summary given analyzing child's development. When analyzing a young child's development progress, consider the child age and then focus your question on the areas of likely current developmental progress. Offer the child suitable toys to find out about skills through play. Observe how the child uses the toys and interacts with people. Developmental screening and assessment. Developmental screening checks of whole populations of children at set ages by trained professionals is a formal process within the child's health surveillance and promotion program. It is also an essential role of all health professionals to screen a young child's developmental progress opportunistically at every health contact. For example, by the general practitioner for a sore throat, in the accident and emergency department for a fall, or on admission to a pediatric ward. In this way, every child contact is optimized to check that development is progressing normally. There are a number of problems inherent in developmental screening. It is a subjective clinical opinion and therefore has its limitations. A single observation of development may be limited by the child's being tired, hungry, shy, or simply not wishing to take part. While much of the focus of early developmental progress in infants is centered on motor development, this is a poor predictor of cognitive function and later school performance. Development of speech and language is a better predictor of cognitive function, but is less easy to assess rapidly. It is likely to manifest at an age when there is increased surveillance by health professionals. The reliability of screening tests can be improved by adding a questionnaire completed by parents beforehand. Screening is being increasingly targeted towards children at high risk or when there are parental concerns. Developmental assessment is a detailed analysis of particularly areas of development and follows concern after screening that a child's developmental progress may be disordered in some way. It is part of the diagnostic process and includes investigations, therapy, and advice on how to optimize the child's progress. Developmental assessment is by referral to a specialist service such as the local multidisciplinary child development service, which is able to offer input by a pediatrician and therapist. A range of tests has been developed to screen or to assess development in a formal, reproducible manner. These include screening tests, for example, the Schedule of Growing Skills and the Denver Developmental Screening Tests. Standardized tests that assess the overall development of infants and young children, for example, Griffith and the Bailey Infant Developmental Scale, which are used, for instance, in follow-up studies of preterm infants. Standardized tests concentrating on assessing specific aspects of development, for example, the renal language scale, the gross motor function measure, the autism diagnostic interview, and the autism diagnostic observation schedule. These tests are time-consuming and require training for reliable results. Cognitive function, higher mental function can be assessed objectively with formal intelligence quotient IQ tests. However, IQ tests may be affected by cultural background and linguistic skills, do not test all skill areas, do not necessarily reflect an individual child's ultimate potential, may be compromised by specific disabilities such as a motor disorder as in cerebral palsy. Verbal reasoning tests, especially those for younger children, reflect general intellectual skills, particularly relating to language. Performance or non-verbal reasoning tests assess abilities independent of language. Verbal and performance testing together with other tests of cognitive functions such as processing speed and working memory allows formulation of a verbal IQ and performance IQ, which together give an overall IQ figure. Children with disabilities may have problems with speech or hand skills that may compromise testing, so that an overall result in these situations has to be interpreted with care. Cognitive higher mental functions assessment of school-age children using IQ and other tests is carried out by clinical or educational psychologists. Now, a short summary: developmental screening and assessment. Developmental screening checks of whole population or groups of children at set ages by trained professionals. Developmental assessment, detailed analysis of overall development or specific areas of development. Now, child health surveillance. In the UK, the Healthy Child program spans from pregnancy to 19 years of age, but the main emphasis is on ages 0 to 5 years. It offers families a program of screening tests, early detection, immunization, disease prevention, developmental reviews, health promotion, information and guidance to support parenting and healthy lifestyle choices. From 0 to 5 years of age, there are a limited number of universal health visitor reviews, antenatal health promoting visit, the new baby review, 6 to 8 week assessment, health visitor or family nurse led check, 1 year assessment, 2 to 2.5 year review. Their aim is to support parents to give their child the optimal start in life and identify if families need extra help. Early identification and treatment of problems to reduce health and social care needs later in life. Review immunization status to ensure full coverage, allow collection of specific public health data At a national level, the program relies on parents identifying problem with health, development, hearing and vision rather than universal screening. Health visitor support is tailored to need, with most input reserved for families with complex needs. Details of each review are entered into the child's personal child health record kept by parents, brought whenever the child is seen by a health professional. Now, this is a table overview of health child program in UK provided by integrated local services. Age screening is done at 0 to 2 years. Antenatal health promotion visit, newborn examination less than 72 hours old, bilirubin check by 48 hours if jaundice, biochemical screening at day 5, repeat newborn examinations at 6 to 8 weeks, immunization, hepatitis B, BCG if at risk, diphtheria, tetanus, pertussis, polio, HIB, and PCV, rotavirus, meningococcal B and C, and MMR vaccine. Developmental reviews, new baby review by 14 days, 12 to 13-month review, health promotion, feeding, weaning, safety at home and in cars, passive smoke, SIDS prevention, and personal child health record and birth to 5 book. From age 2 to 10 years, preschool vision and hearing screen, national child measurement program 4 to 5 years, immunization, children's flu, MMR vaccine, and diphtheria, tetanus, pertussis, and polio. Developmental reviews 2 to 2.5 years, ages and stages questionnaire, preschool review, and health promotion, nutrition, obesity prevention, injury prevention, and emotional health, psychological well-being at 10 to 19 years, national child measurement program 10 to 11 years, screening. And immunization, tetanus, diphtheria, polio, meningococcal, ACWY, HPV for girls. Developmental reviews, health review at school transition at 10 to 11 years and 15 to 16 years, questionnaires, health promotion, encourage physical activity, emotional health, psychological well-being and mental health, reduction of risk-taking behavior, and sexual health. HIB stands for human influenza type B, HPV is human papilloma virus, MMR is measles, mumps, rubella, PCV is pneumococcal virus, SIDS sudden infant death syndrome. Next is a little summary. Child health surveillance and promotion program. It is provided in primary care, includes screening, immunization, developmental reviews, and health promotion. Emphasizes the role of parents in the early detection of problem with health, development, and hearing and vision. Next is hearing. During the later stages of pregnancy, the fetus responds to sound. At birth, a baby startles to sound, and there is a marked preference for voices. The ability to locate and turn towards sounds comes later in the first year. Hearing tests, newborn, early detection and treatment of hearing impairment improves the outcome for speech and language and behavior. In order to detect hearing impairment in the newborn period, hearing can be tested as autoacoustic emission, as in the figure. An earphone produces a sound which evokes an echo or emission from the ear if cochlear function is normal. Auditory brainstem response, ABR, audiometry, as that is as in the figure, computer analysis of electroencephalogram waveform evoked in response to a series of auditory stimuli. Universal neonatal hearing screening has been introduced in many countries since 2006. In the UK, OAE testing is offered as initial screening in well babies. This is often done before the child leaves the hospital, after birth, or within the first few weeks of life. If the test is abnormal, the infant is referred to an audiologist and ABR audiometry is carried out if necessary. Babies on the special care baby unit are usually screened with both OAE and automated ABR. Hearing tests in notice children are shown in figure 3. Next figures. In these hearing tests, hearing screening of newborn infants, A is autoacoustic emission, click generations from earphones, detects normal sound vibrations. Advantages: simple and quick to perform, though is affected by ambient noise. Disadvantages: misses auditory neuropathy as function of auditory nerve or brain. Not tested. Relatively high false positive rate in first 24 hours after birth, as vernix or amniotic fluid are still in ear canal. Not a test of hearing but a test of cochlear function. Next is auditory brainstem response, ABR, auditory nerve to brain. Auditory stimulus starts with auditory stimulus via earphones and then signal via ear and auditory nerve to brain. And then EEG waveform computerized analysis determines if normal or abnormal. Advantages: screens hearing pathway from ear to brainstem, low false positive rate. Disadvantages: affected by movement, so infants need to be asleep or very quiet, so time consuming. Complex computerized equipment but is mobile. Requires electrodes applied to infant's head, which parents may dislike. Next figure is the hearing test. Number one figure that you see is distraction hearing test. The test is hard to perform reliably at babies with hearing difficulties learn to compensate by using shadows, smells, and guesswork to locate the presenter. The test must be done by well-trained professionals. The next picture is speech discrimination testing using miniature toys to detect hearing loss in children between 18 months and 4 years of age. Next picture is visual reinforcement audiometry. While an assistant plays with the child, sounds of a specific frequency are emitted from a speaker. When the child turns to it, the tester lights up a toy by the speaker to reinforce the sound with a visual reward. This test is particularly useful at 10 to 18 months of age. Now, distraction testing. In the text, this was the mainstay of hearing screening but has been replaced by universal neonatal screening. It is now only used as a screening test for infants as at 7 to 9 months of age who have not had newborn screening or cannot tolerate or cooperate with more complex testing. The test relies on the baby locating and turning appropriately towards sounds, but before the child develops the ability for object permanence, that is the ability to remember that an assessor is standing behind them even without seeing them. High frequency and low frequency sounds are presented out of the infant's field of vision. Testing is unreliable if not carried out by properly trained staff because it can be difficult to identify hearing impaired infants as they are particularly adept at using non-auditory cues. Visual reinforcement audiometry. This is particularly useful to assess hearing impairment in infants between 10 and 18 months of age. Although it can be used between the ages of 6 months and 3 years, it is also used in some older children with learning disability. Hearing thresholds are established using visual reward, illumination of toys to reinforce the child's head turn to stimuli of different frequencies. Localization of the stimuli is not necessary, and insert earphones may be used to obtain ear-specific information, thus making it more useful than field tests such as distraction and performance testing. Performance and speech discrimination testing. Performance testing using high frequency and low frequency stimuli and speech discrimination testing. Using miniature toys can be used for children with suspected hearing loss at 18 months to 4 years of age or for older children with learning disabilities. Next is audiometry. Threshold audiometry using headphones where the child responds to a pure tone stimulus can be used to detect and assess the severity of hearing loss in children from 4 years of age. Parental concern at all ages. Parental concern about hearing warrants further assessment. A checklist for parents of normal hearing responses during infancy is shown in the next table. Hearing checklist for parents. Shortly after birth, startles and blinks at a sudden noise, for example slamming of door. By 1 month, notices sudden prolonged sounds, for example a vacuum cleaner, and pauses and listens when they begin. By 4 months, quietens or smiles to the sound of your voice even when he or she cannot see you. May also turn the head or eyes towards you if you come up from behind and speak from the side. By 7 months, turns immediately to your voice across the room or to very quiet noises made on each side, so long as not too occupied with other things. By 9 months, listens attentively to familiar everyday sounds and searches for very quiet sounds made out of sight. Should also show pleasure in babbling loudly and tunefully. By 12 months, shows some response to his or her own name and to other familiar words. May respond when you say no and bye bye, even when cannot see any accompanying gesture. If you suspect that your baby is not hearing normally, seek advice from your health visitor or doctor. Now, a little summary. Points: hearing, early detection and treatment of hearing impairment improves the outcome of speech and language and behavior. Newborn hearing screening is performed for the early identification of hearing impairment. If there is parental concern about hearing, further assessment is warranted. Next is vision. A newborn infant's vision is limited. There is some visual awareness of light sources, faces, and areas of high contrast. Visual acuity is low. Large targets can be detected at about 30 centimeter distance but appear fuzzy. The peripheral retina is well developed, but the fovea is immature and the optic nerve is unmyelinated. Well-focused images on the retina are required for the acquisition of visual acuity, and any obstruction to this, for example from a cataract, will interfere with the normal development of the optic pathways and visual cortex unless corrected early in life. This type of visual loss can be permanent and is called amblyopia. In the first few weeks of life, infant develops the capacity to maintain fixation on a moving target such as a face or dangling colored ball, though they may have a transient squint. By 6 weeks of age, most babies can perform this task. By 5 months of age, a baby can fixate on a 2.5 centimeter block. By 12 months, on a 1 mm, hundreds and thousands cake sprinkles. Clarity of vision also matures. Visual acuity improves from 6/200 at birth to 60/60 at 3 months and 6/6 at 5 years of age. Vision testing. The assessment of vision at different angles is shown in the table. In the UK, orthoptist-led screening is recommended for children aged 4 to 5 years to detect reduced visual acuity, primarily amblyopia. And testing vision at different ages. At birth, aware of light, may fix and follow horizontally a face or large colored toy. 6 to 8 weeks, face fixation and following large colored toys. 6 months, fixates 2.5 centimeter brick, visually directed reach, responds to preferential looking tests of acuity, for example Keeler or Teller cards. 12 months, he or she fixates 1 mm crumb. 1 to 2 years, preferential looking test of acuity, for example Cardiff cards. 2 to 3 years, names or matches pictures in linear array, for example K pictures or Leah symbols. Distant and near. 3 years plus, names or matches letters, for example Songtsen Longmar or Longmar crowded. Distant and near. Note: using single letter pictures should not be used, as these overestimate acuity and will miss significant interocular differences, i.e. miss amblyopia. At all ages, observe the child's eyes. Is eye contact established? What is the child looking at? How does the child respond to what is apparently seen? So this is end of chapter 3. Thank you.